We just have a handful of slides here to talk about Telestroke, and so I would say that when Tom and I have been around talking to, and Noreen, and we've been at many of the sites. A lot of the delays are certainly perceived to be related to the Telestroke process, and as Andrew was telling you, we're trying to integrate this process into understanding how to move people for endovascular therapy where appropriate, and maybe it'll be 1 in 5 or 1 in 6 acute strokes, but having a plan in place. So there's and then integrating also with EMS as well. So trying to figure out standardized ways to integrate all the communications so that everybody will get what's need to happen. So there's a sheet in your package. Maybe if you could all pull it out and have a look at it. We're going to go through components of it, and what we're trying to do is again standardize this. This can be an open forum. We can have a discussion now about some of these concepts. We want to integrate the terminology in here so that everybody's getting the same terminology as we go through. So we're going to break it down in bits.
So this is a comprehensive overview, but for sites, sometimes it's also useful to create your own very linear flow map, which has been useful, whereas this is kind of a gestalt of the whole process. It's not always easy to look at this and figure out what your next step is, but it's a great overview of what's happening in the whole process. But for example, other sites have created a much more linear, sequential, site-specific map based on this, which is also a very useful exercise. So the first part, if we go right back to the beginning, essentially the EMS crew responds to the stroke patient from wherever they originate. And then in transit, the EMS crew pre-notifies the primary stroke center of the STAT stroke protocol. And that's based on an acute stroke in the window and one or more of the red findings. So the ER nurse receives the notification and actually preps locally for the arrival of the patient.
And then what's going to happen, right? I'm just going to jump in back and forth to this tag team. But as Renee Andrew showed you the evolution of what's going to happen with endovascular is that as the LAM score gets promoted all around the province, then the paramedics are going to patch in and say, I've got a 65-year-old guy, hemiplegic, LAM score of 5, right? ETA 10 minutes, last seen normal, et cetera. And then you'll have that information and give you the vitals as you come in. So you're going to get that information. We're going to also, the other thing is that I'm also going to encourage the paramedic teams to patch in as early as possible, right? So I know, and Tom will give you this, and Muzaffar and others are the same thing. It's terrific when we have at least a 10-minute heads up. It's terrific for triage. It's terrific for everybody to at least 10 minutes to know. When you get a 2-minute heads up, it's pretty hard, right? Or if they're patching you from the time they're pulling in, it's not. But obviously things happen. Patients are unstable, and we get that. But this is what we're going to try to move towards.
Yeah, we appreciate the heads up as well. In fact, our fellows are out of house. Calgary's are in house. Ours are out of house, and we appreciate a pre-hospital notification, especially after hours, and that lets the fellow meet the patient in the ED. Makes a big difference. It can make the difference between a timely treatment and a slow treatment. So the next part basically is the piece that's going to be new is the ER nurses will be trained to do the LAMs as well. So your triage nurses will actually be doing a LAM score, and that'll actually be useful in the process to figure out whether this patient has to go to a tertiary center and when we start the transport process, and that's actually what's important to know. So at the same time when the patient actually arrives, that's when the ER nurse LAM score will be done, and that's actually when the heads up goes out to the telestroke physician or to the stroke team or through Rapid. And in the north, it's the Telestroke doc. In the south, it's going to be the Calgary Stroke Program responding. And at that point in time, the LAM score is actually going to feed into initiating an early transport process or not, depending on what the score is. And if the LAM score is going to be 4 or more, then that's going to trigger CCC, provincial flight, STARS, transport physician coming on the line to start the process of transport even prior to the patient being treated. So what that means is it's very practical. CCC is going to start planning. They're going to start doing weather checks. They're going to start to turn on the helicopter. Roll it out of the hangar so it starts to warm up. plug it in, the block heater or whatever they have. The same thing with the fixed wing. So the fixed wing takes a little bit of time to warm up. It takes about 20 to 25 minutes for these vehicles to actually get to flight mode. And the timing actually, hopefully, is going to work out well for us in terms of having the vehicles flight ready by the time we actually have a decision on transport, maybe 20 minutes later, after the rest of the process rolls out.
The goal is that if you identify LAMS 4 or greater, either the paramedics have told you, or at the triage desk, the triage nurse is going to say, yep, clearly they're hemiplegic, LAMS 4, LAMS 5. When you call rapid, you say this is a red referral, LAMS 4 or greater, and then that will initiate this whole process of getting everybody up to speed. What we've been told about air ambulance and weather and transport and from the support physicians is that, as Tom said, it takes time to get things sorted up. And so routinely, we're piggybacking on an existing process. This was what already happens in trauma. It already happens in MI, so that they are quite happy to roll the helicopter out of the hangar, start it up, because at least 50% of the time they just stop and roll it back in again. So we are not wasting resources doing this. We are doing this, we're just piggybacking on an existing system, and the same is true for fixed wing, right? You wheel the planes out of the hangar, the fixed wing ambulance, get them warmed up and get ready to go. By that time, hopefully, we'll go down through the rest of this process. You've assessed the patient, a CT's been done, and it's going to become clear whether this patient is going to be a transport patient or not. And it'll be okay to stand down, right, at that point, if it is a stand down, and if it's not, then everything's geared up and ready to go. Okay?
So at some point, maybe in the future, when the ambulance crew actually has their red referral process come up positive, we're going to be patching the stroke neurologist into this conversation and talking about bypassing the primary stroke center entirely. We don't quite have that pre-hospital piece worked out just yet, so that might be something we'll see in the future.
We're getting ready for the December rollout of the paramedics and the call that Andrew talked about. And in anticipation of that, over the next 9 months, what we're going to have is this rapid process with red referral and LAMS from the primary center, which will then easily feed into the same thing as when we get the paramedic rollout. So the single change that Rapid has agreed to is that when you call Rapid, if you say to them, this is a red referral and this is a LAMS 4 or greater, then they're going to get the transport team on the line, the critical care line, the coordinating center for community. They'll get everybody on the line and start this process of arranging a transport, right? So they'll get stuff going in the background while you are then taking care of the patient at the PSC.
So at this point in time, the Telestroke doc gets the notification. So it's not pre-notification, it's notification. The patient's actually in the hospital by the time Telestroke gets involved. Why that is because at that point in time, you can give us a ULI, you can give us a name, the patient's in the primary stroke center. We really do want to know at this point in time. Telestroke, for the last several years, we don't get called after the CT scan's done. All right? I mean, occasionally maybe, because the patient's in the scanner when we're called. But the point is, we need that heads up when the patient arrives. It's really important. We don't need everything tied in a bow 30 minutes later to be called. We need to be called right away. And then we'll be on net care, looking the patient up, looking at their past history, refreshing the impacts images to try to actually see the images as they come up as they're pushed from the primary stroke center. So we're going to be prepping, checking the patient out electronically while this is all happening, while your patient's actually in their scanner. If you call us 30 minutes prior and you don't have a name or a ULI, we'll just sit up and have tea or something, or try to sleep, and just get back to sleep by the time the notification call comes in. And so the point is, we can't do as much practically. We're used to responding quickly when we get the heads up, so that's when we need to get it when the patient arrives. Okay, it's notification. All right, so the LAMS score, and it's a relatively simple score. It's already basically incorporated into the pre-hospital screen anyway. So I'm going to do it on Michael.
Sure.
That's okay. All right, so he looks pretty nervous. He looks like an NIH no more than 10, so I think I'm probably wasting my time. So anyway, what we're going to standardize is exactly what the prompts are. Because the reason the NIH is so good is because there's a standardized way to get every practitioner to do it the same way. And so we need the same thing for our EMS training and LAMS, and that's going to make the score more reliable, as opposed to just allowing them to interpret things. So I'm going to check out Michael, and I'm going to ask Michael.
This way, okay, so
yeah,
you can
all right.
see.
And I'm going to ask Michael to grimace. Can you smile for me?
But yeah,
I'd say that's closer to seizure activity.
Okay.
That's pretty good, actually. So Michael did good. It looks pretty symmetric right now. And the next thing is we're going to do the motor score. So I'm going to say, can you lift your arm up? All right. Now, okay, so the right arm drifts. Can you lift the left arm up? And it stays up. Okay. And then we don't check the leg for the LAM score. I get Michael to check grip.
Grip. So
all
you
right?
just grip strength.
So that's a little weak. It's a bit wishy-washy. Oh, he's been working out for sure. So this one's actually pretty strong. All right. So I've got a LAMS now with I'll call that a facial droop. So we'll give that a 1. His right arm drops down basically quickly. I'll give that a 2. And then he's got a weak grip. So he gets another 2 for his weak grip. So he makes a 5 on the LAM scale. So it's a red referral. If it was a 4, it would also be a red referral. Okay. So that's the kind of standardized process we're going to have when they roll out this educational tool to EMS.
It's very similar to the motor components of the NI stroke scale score, as you'll appreciate, right? And it turns out that it has, the one thing about it is it may not pick up, it's not as sensitive. It won't pick up all cases that have a large artery occlusion, but it's highly specific, which means that if you have a score of 5 or so, it's a high probability that you do actually have a large artery occlusion. So you can count on it a bit more than some of the other scores, but you must also be wary that you will sometimes get false negatives. So you'll have a LAM score of 3, you'll go and do your CT and CTA, and you realize, oh my God, there is an M1 occlusion here, and then you have to there's going to naturally that will induce some delays in the transportation process. We accept that. We accept that's going to happen. So we have to have a score that's going to be simple for people to use, both in the field and at triage, right? And help us to get most of the people with these large artery occlusions on the road for endovascular therapy. That's what it's for. Okay.
I'm actually glad that you've questioned my math skills here because the point is this drifts down. Or is this drifts down, all right? So the point is you got to standardize what we actually consider to be a positive response to actually make the scale, and different people might have a different idea of what an immediate drift down means, all right? So I'm glad you brought that up. All right, so I'll practice my math in the meantime. So the next thing is imaging, all right? And so what we have here is, this is like the tiniest red dot I've ever seen. But so obviously the non-contrast CT scan is the fundamental study that's done. But we have in series obtains a CTA scan right away because we want to emphasize that really we want both to be done. Ultimately, if the health system could do them both right away, it would be great. That's not always the case, which we'll get into in my next talk. So the CT scan gets done, and then later the patient's moved to a space with telehealth equipment. So this is what's happening to the patient. So for diagnostic imaging, they're completing the scan. What's important here is certainly in the north for the Telestroke system, and a lot of the times you have to push the scans to the server as well, just like the situation with your Philips scanners. They aren't automatically accessible to me unless you push it to the UH server, which all your CT techs know now. But what happens is we want you to push the non-contrast scans first, ideally the axials, because they come through faster. It's a smaller file size. I can open it up and look at it and make an immediate decision for TPA once I've checked out the patient. All right, if you do the CT angio at the same time, or if you do other things like some centers do coronals and axials and sagittals as well as the axial, like they do them all together and it takes longer to do, we're going to delay the transfer of those images. It's a much bigger file size. So just send the plain axials first and then send the rest afterwards, okay? And the target is a door to first slice of less than 10 minutes. Any comments, Michael?
Yeah, I'll make one comment that came up when we were visiting in Peace River was the issue of should you be doing a CT and CTA just straight ahead and do it, or should you be doing a CT, stopping, going back to emergency, giving TPA, then coming back for a CTA, and so I think in general we prefer the former, where you're just go ahead and to have it as a standardized protocol that you're going to image people. The standard is going to be a CT and CTA directly. We're talking with Mona from Peace River about pushing scans, so it turns out in many scanners it's relatively straightforward. After the plane head is completed, you can hit the button and send it to the PAC system and then just carry on with the CTA. By the time that Tom's been able to review it and get it back, you'll have all the imaging done, and then you can move the patient back to a treatment area. It just makes it's easier for patient flow. If the patient has to go to the CT, back to emerge, back to the CT, back to emerge, then you are going to introduce a lot of extra delay in your whole treatment process. And so if you can streamline it that way, that makes it really, really straightforward.
The next thing is the patient's moved to a space with the telehealth equipment. So for DI, this isn't happening with DI, but it's happening in the ED. They're connecting up the telehealth equipment, all right, so that we can have a video conference if we need to. And then what's happening here is the Telestroke doc now is refreshing the impacts program to see when that CT scan comes up. That's usually what we're doing. And then as soon as it comes up, we'll then call back into Rapid usually and talk to the doc afterwards. Sometimes the doc is already calling us back to Rapid because the patient has gotten back to the ED before I've had a chance to look at the CT scan. So we should both be aggressively trying to reconnect with each other once those CT images have been reviewed or once the patient gets back to the ED. It shouldn't be just on one side. We should both be trying to reconnect at that point in time, okay? We've also talked about possibly, not having a second call and going direct to video conference. And that's an option as well. I mean, to actually have the next meeting on video conference. And I find that actually works some of the time, and it's actually really, really quick. So the next time you meet on video conference, you're talking to the doctor directly. And if you've got questions about time of onset from the family, well, they're on the video conference too. The patient's right there. All the information is being gathered all at the same time, as if you're in a room with them doing a consult. All right, as opposed to me asking the doctor, well, what did the wife say about time of onset? So it's, Muriel, what did the wife say about time of onset? And then Muriel asks the wife who's in the next room, and then it comes back that way, and I can hear this going on in the background. Well, it's sometimes faster just to get everybody in the same room together. But sometimes when I call back and connect with the doctor will say, oh, this patient's totally aphasic, they're hemiparetic, and there's no contraindication on the CT scan, there's no contraindication on neck care. I get the history from the doc who happens to have it. We can make a thrombolysis decision on the phone. And I can say, I want you to give TPA, aim for a bolus in 5 minutes from this moment in time, and tell them to turn on the equipment, which is usually on anyway. The equipment's almost always on, but they have to just dial into the conference bridge. And so sometimes we can actually thrombolyze faster by that reconnect phone call. So either way will actually work. It just depends on the circumstance.
I think the sort of general idea is one heads-up call from Rapid at the beginning, and then you're reconnecting again either on the phone, having viewed the images, or you're reconnecting at the televideo conference bridge with everybody. But there's just the two reconnections, right? And I think, as Tom says, probably 8 times out of 10, you can make a reasonable decision about thrombolysis based on reviewing the images and just having a discussion with the treating physician. It's helpful maybe 2 times out of 10 to actually see the patient if there's something unusual about the story or the exam or that kind of thing where you would maybe decide not to treat depending on how the patient looks. So the video conference helps, but it's that one little adjuvant extra.
Yeah. I personally think that the video conferences do add to the care. When we see patients in neuroclinic, we don't just do phone consults with the doc. There's something more rich about actually examining the patient and checking them out. And sometimes I've had a great description of aphasia from a doctor, and I check them out online, and I can tell the patient's postictal. Or I can tell it's a delirium. It's clearly a delirium. It's not actually aphasia. So it's kind of a picture's worth 1,000 words, but then in certain situations where it's a classic presentation, I'd say about 1/3 to 40%, or maybe even 50%, you could make a decision by phone right there to say, look, this is a clear-cut decision, give thrombolysis right now. All right, so it could go both ways.
And then the added bit's that will arrive will be then the next will be a decision about transport, and that will be again informed by both review of images and what the premorbid status of the patient looks like. That's what's going to help you, and then obviously hopefully the transport process is already in play, and either you're going to stand it down because it's not going to be a transport case, or you're going to accelerate it and try and move the patient quickly with a fast door in, door out time.
So that is the last part here. So we move to a situation of thrombolysis. Sometimes the bolus is given before the video conference. Sometimes the circumstances at the site are such that the doc's got to go intubate somebody or there's a technical issue, they can't do the video conference, but oftentimes they can. And so that can be frequently part of the process. And then we have to decide on the next step, which is endovascular treatment. And it gets a bit complicated when it's after hours and you're in a site that doesn't have a CTA tech in-house that can do the CT angio. Because remember, we have a helicopter waiting. And so we just gave thrombolysis. And at this point in time, the tech has now come in. And what we want to do ideally at this point is once TPA has been given, we've made a thrombolysis decision. And once we know whether or not the patient's an endovascular candidate, we want to reconnect with Rapid right away. Because we want that STARS physician, CCC, provincial flight, back online, because we want to tell them what to do with their helicopter or their fixed wing. Do they just keep burning jet fuel, or do they launch? What do they do exactly? So we're going to have to work it out in the ERA discussions. What happens at that point? If we're still waiting for the CT angio to be done and the tech is still coming in, which is sometimes the case, if it's we have to work something out. So if it's a high NIH stroke scale, I would advocate that we should launch those vehicles, and they should get in the air. And then, if by the time the CT angio is done, we find that the vessels are open, then the vehicle stands down and reverses, or something like that. Hopefully, though, for most centers, we will have had the CT angio done by this time, because really that's a really important piece of information that helps us with the endovascular transport.
The thing I would add is that there are other reasons to transport patients as well. So patients have hemorrhage, and they may need they may need neurosurgical care, although that's less common, but they may need neurocritical care, which is not available in your site. Patients have a large evolving stroke, and they're young. They may also need surgical care and evaluation. So the decisions to transport can be included in this whole discussion. There'll be the obvious idea that we want to decide to transport for acute intervention, and then if not, then there's an opportunity potentially for other types of care which may be not available elsewhere. A lot of small sites don't have an ICU with intubated, ability to maintain intubated patients. So those are kinds of things where people, if they're really sick, they're going to need to come anyway. So I think that even though we may not transport everybody for neurointervention, we may also be transporting people for essentially a higher level of care.
Yeah, I think that's a great point. Yeah. So that's the end of our slideshow.
Okay. Any comments about that?